part 1, you have learned to take a history, do an examination, and make a clinical diagnosis. In part 2, you have understood what are the surgical options and how to select the right choice for the patient. In this part 3 of the facial nerve palsy, we shall discuss about the course and the anatomy of the facial nerve and how to determine the level of injury by doing various tests. So let us discuss about the part 3. In the previous part 1 and part 2 of facial nerve injury, you have come to know about the detailed history, the examination, the investigation, and the management of a patient suffering from facial nerve injury. In this part 3, you must be able to recall the entire course of the facial nerve and its applied to face. And you should also know about how to assess the level of injury clinically. So the first question is that how will you do the clinical assessment of the level of injury? Remember four things. The first is the examination of the taste. You have already inquired about the alteration or loss of taste sensation in the history part. If it is present, that it indicates the injury to the cauda tympani nerve within the bony facial canal. If the patient has an existing complaint of increased frequency of sound, which is hyperacusis, then it indicates that there is an injury to nerve to stapedius and the level of the facial nerve injury is within the bony facial canal. You have already inquired about the dryness of the nose, mouth, or eyes. If any of these is present, then there is an injury to facial nerve near the geniculate ganglia. You must perform the Shermer's test. Place a strip in the lower fornix of the patient on the affected side. Ask him to close the eyes for 5 minutes. And then you take out the strip, measure the vertical extent to which it has become wet. If it is less than 10 millimeter, it indicates insufficient air production. So something about the taste sensation. So you must know that there are four types of papillae on the tongue. On the surface of the tongue, there are fungiform papillae which contains the taste buds. There are filiform papillae which do not transmit taste sensation. Instead, they transmit touch, temperature, nociception. On both the lateral sides of the tongue, there are foliate papillae, and then on the base of the tongue, an inverted V shape is formed by the presence of the circumvallate papillae. For basic test sensation, you must know and you must test for it in the patient. So usually sweet and salty are at the tip of the tongue. The sour taste is on the sides of the tongue and the bitter taste is at the posterior surface or the base of the tongue. So again emphasizing that from the anterior two-third of the tongue, taste sensation is being carried by the cauda tympani, a branch which is given by the facial nerve in the bony facial canal. And from the posterior one-third of the tongue, taste sensation is carried out by the glossopharyngeal nerve. Now here you may be asked one question that what is the importance of the lower eyelid from the functionality point of view? So remember that normally there is no movement of the lower eyelid. It remains static, there is no scleral show. But if the patient smiles or squints, then there may be an upward movement of 1 to 2 millimeter of the lower eyelid. So the major functional importance of lower eyelid is in the drainage of the tears. So on blinking the eyelids, the tear film it spreads from lateral to medial inferior fornix and from there it goes to the inferior and the superior puncta. And finally, the orbicularis oculi provides a pumping action to the lacrimal sac, which leads to the effective drainage of these tears. So related to this, one question is asked that why dryness and watering they occur simultaneously in a facial nerve palsy. So remember, due to the paralysis of the muscles, there is dryness and the corneal exposure, which leads to reflex production of excessive tears. And this excessive production, along with the ineffective drainage, lead to excessive watering, which is also known as epiphora. So This usually increases when the patient inclines his head downwards, especially while reading or doing some near work. So, all these things have to be inquired in the history, and you must know the scientific basis. Now, let us come to the course of the facial nerve. Facial nerve has got an intracranial course and an extracranial course. In the cranium, it originates from pons as two roots, a larger motor root and a smaller sensory root. Then these two roots, they travel through the petrous part of the temporal bone in the internal acoustic meatus, approximately 1 centimeter uh, distance. And then it leaves the internal acoustic meatus and enters the bony facial canal within the temporal bone. In this bony facial canal, the two roots join to form the facial nerve and the geniculate ganglion. Now, within this bony facial canal, the nerve gives three branches. Greater petrosal nerve, supplying parasympathetic fibers to the lacrimal gland. Nerve to stapedius, which supplies the stapedius muscle in the middle ear. And the cauda tympani, which carries the taste sensations from the anterior two-third of the tongue. And cauda tympani also carries parasympathetic fibers to the submandibular and the sublingual glands. So within the bony facial canal of the temporal bone, three branches: greater petrosal nerve, nerve to stapedius, and cauda tympani. Now the nerve leaves the bony part by exiting through the stylomastoid foramen. And this point is located deep to the styloid process of temporal bone. So come to the extracranial course of the facial nerve. On immediately exiting out of the stylomastoid foramen, there are three branches: posterior auricular nerve, nerve to posterior belly of digastric, and nerve to stylohyoid muscle. After giving these three branches, the facial nerve becomes superficial and it passes between the superficial and the deep portion of the parotid gland. Within the substance of the parotid gland, it divides into two main trunks. Now, these two main trunks, they again divide to form 8 to 10 branches, and these branches further divide and connect with each other, so that there is much overlapping between these branches which supply the facial muscles. So now the question comes, what are the major divisions of the facial nerve in the face? So the first is frontal temporal branch. It is usually 3 to 4 in number. On its origin, it runs deep to the temporoparietal fascia and it crosses the zygomatic arch 3 to 5 centimeter lateral to the lateral orbital wall. The upper two branches, they supply the frontalis muscle, and at this level, it lies 3 centimeter above the lateral canthus in the subcutaneous plane. So remember, from deep, it comes to lie in the subcutaneous plane. Here you must remember two facts. What is the relation of these frontal temporal branches to the frontal branch of the superficial temporal artery? So the nerve lies 1.5 centimeter inferior to the artery. And there is also Pittinguy's line. You will join a line from joining the tragus and the lateral canthus, and this frontotemporal nerve will lie 1.5 centimeter above this line, superficial to the temporoparietal fascia in the subcutaneous plane. So at this level, the dissection should be deep to TPF. If you will do the dissection in the subcutaneous plane, then you have to remember the course and identify the nerve and preserve it. This frontotemporal branch, it supplies the frontalis, orbicularis oculi, and the corrugator supercilii. The second is the zygomatic branch, which supplies the muscles of the middle face. The third is the buccal branch, which supplies the muscles of cheek, including the buccinatus. And these buccal branches are 3 to 8 in number, much of overlapping and interconnection, so that one of the branches paralysis may not lead to that much weakness. They supply the lower orbicularis oculi, buccinator, orbicularis oris, and the elevators of the lip. Remember. So at this level, these buccal branches, they lie in the same plane as the parotid duct. The fourth is the marginal mandibular branch, which is 1 to 3 in numbers, and it usually runs 2 centimeter below the ramus, crosses upward at the middle of the mandibular body, and it supplies the lower orbicularis oris, depressors of lip, and the platysma. So elevators of lip are supplied by the buccal branches. Depressor of lips are supplied by the marginal mandibular branches. These branches, they run deep to the platysma and they are superficial to the facial vessels. So all these relations must be remembered when you are dealing with a facial nerve palsy and if you are doing some dissection in the face. The fifth branch is the cervical branch, and the cervical branch is usually a single branch and it enters the platysma and on its deeper surface below the angle of the mandible. So with this, we come to the end of the course of the facial nerve and the assessment of level of injury. And there might be other questions which can be asked to you. Classify facial nerve injuries, the name of the muscles responsible for facial expression, and how will you perform the different muscle transplantation for eyelid reanimation and smile reconstruction. And with this part 3, we have completed the chapter on the facial nerve palsy. I hope you had a great learning on all the three parts. And so stay tuned. Thank you so much and happy reading.